This is the Healthcare Consumer Access and Affordability Senate Select Committee, and today is September 7th, and we're planning on going till approximately 10:45. Are there any items of business that any of the senators would like to bring up? Seeing none, are we okay on the mic, Bailey? Okay, sounds good. We'll dispense with introductions. We've done that before, and we'll go straight into our first presenter. I want to thank Mr. Stefan Gildemeister for being willing to present to us, and he will be talking about the analysis of low-value medical services. If the presenters wouldn't mind one reminder, I would just ask that everybody try to incline your comments as much as is possible towards actionable items. What we ultimately would like to do is allow this committee to put forward perhaps, if you will, a potpourri of ideas or concepts that we could legislatively pursue in the 2018 session. And you folks are helping us immensely. We've had the privilege of hearing Mr. Gildemeister previously, and he is not only articulate and insightful, I would just remind everybody that he is a father. So congratulations again, and please introduce yourself and take off.
Thank you, Mr. Chair, for the kind words. I did not get a lot of sleep, so there's another excuse. For the record, my name is Stefan Gildemeister. I direct the Health Economics program in the Department of Health, and I'm the state health economist. So thank you again for inviting me a second time to speak to this committee. And moving quickly, I think what I'm planning on doing is to speak briefly about health inefficiencies more broadly, place low-value care in the context of this broader group of analysis, talk about our results, and then speak to lessons and next steps. Speaking of steps, I'm going to step a little lightly on giving you solutions because I'm not sure that that's perfectly appropriate for my role, but what I can do is speak to what I've seen in the literature and what I've seen happen in other states. And hopefully that provides a good basis for you. Last time when you were so kind to have me, I showed you some data on estimates of health system inefficiencies in the U.S. healthcare system, and it's that number that we've been carrying around for more than 10 years, that about a third of healthcare spending in the country is wasted. We don't know whether that is true in Minnesota. One hopes that with the innovation of providers and payers and with the measurement landscape that we've had in place for more than 10 years, that the share of spending wasted is lower, but we know that the categories of wasteful spending that we see on this chart clearly exist in Minnesota as well, and we've documented some of this. In any case, the legislature has directed us as the health department to look at conduct research and data initiatives that help monitor and understand how to improve efficiency and effectiveness of care, and some of the work that I've relied on previously fits in that portfolio. We're looking annually at healthcare spending. We implement mandated quality measurement approaches and to track progress. We study barriers to care as a result of cost. We analyze how changes in employment in the employer market, where most of us have insurance coverage, affects healthcare access and use of services. And then we look to estimate inefficiencies through regional variation analysis and studying non-recommended care. And that's really where I want to focus on today, which probably fits the best in the category of overtreatment. But before I jump into that, I still want to make 2 points. Overtreatment, non-recommended care. It's not the only or even the biggest category of inefficiency in the healthcare system, nor is it the only one that we know something about. So, for instance, failures of care delivery speaks to prevention and the impact of reducing degree of chronic illness or worsening of chronic illness, care coordination. We've learned a lot from the Healthcare Home Initiative. Pricing failures, there's a lot of good work happening in Minnesota that sort of shows how much variation there is for us then to ask the question whether that makes sense and how to affect it. But to speak about non-recommended care, there's a bunch of analysis underway. The low-value services work that I'm speaking about today. We've also conducted estimates of potentially preventable healthcare events, ED visits, readmissions, and preventable admissions. And there's a number of other interesting work, interesting work underway that we're happy to share with you when it becomes available. I wanted to make one point here in saying none of this work would have happened had it not been for the foresight of the legislature to create a data system that allows us with more granular data to analyze, to help understand complex questions of healthcare delivery across the spectrum of care over time and with specific transaction prices. So understanding how the healthcare system works in detail, being able to look back, is what is necessary to do a fairly reasonable low-value services analysis. So for instance, when I talk about uncomplicated low back pain, to determine whether an imaging procedure was a low-value service, we have to go back in time to ask whether there are structural complications that in a year back or so that made the CT necessary or not. So the data and your foresight have been really important, and we call this the Minnesota All-Payer Claims Database.
It's all based on claims, so this really doesn't intrude on providers and things like that, do they? Because they're not being asked to report in that. You're able to gather data simply by looking at claims, looking at how many CAT scans, MRIs have been ordered, seeing who the ordering physician was, things like that. Is that correct?
More or less, yes. The data flows from providers to health plans and then to the state. So provider, specialty, NPI, that information is there. But the reporting of the data, the collection of the data, does not present a burden of healthcare providers. These are, for better or worse, we don't have great data in healthcare. The administrative claims records are created to pay a claim, but we as the broader research community have learned to use it to some great extent in Medicare and beyond to help understand some of the challenges in healthcare.
Thank you, Mr. Gildemeister. I would just share with the committee that part of the reason I asked that question is to identify the difference between data that's retrieved from claims data versus data that, if you will, takes a lot of time from a physician or a physician's office where they have to fill out forms, fill out reports, and things like that. And I think there's a huge difference, because we will be at times in this committee talking about some of those metrics that we have to respond to and some of the obligations, and this is causing a problem as well. I think it's also important to realize that the electronic health record in physician offices and in hospitals is really not contributing to this. This all-payer claims data process is more related to a practice management system that's involved with billing. And so that data is available. So again, I just want to distinguish that what Mr. Gildemeister is going to be able to report to us on will come a lot from claims data, but it will not necessarily have been, if you will, added to in any significant way from an electronic health record or specifically having physicians having to fill out paperwork and things like that. So with that, Mr. Gildemeister, please proceed. Thank you.
Mr. Chair, thank you, for the clarification as well. So low-value care, what do we mean by it? By some measure, this is really about healthcare services and procedures that have been shown to provide little benefit, or in some cases have the potential to cause harm for patients. It's not a new concept. I think we've heard about it under the broader category of overuse, demand-sensitive and supply-sensitive care out of Dartmouth, but most recently and perhaps most effectively under the category of choosing wisely, an initiative that was sponsored initially by the Board of Internal Medicine, but it has grown since then. I'm not going to talk much about the institution or the initiative of choosing wisely, because I think Ms. Krause will do this in a moment. But just to mention that it is one area that has pushed our understanding of low-value care and our the availability of categories under which we measure things as low-value care forward quite a bit, even though there's still work to do. Costs are not always part of the discussion of low-value care. I think the focus oftentimes is also on preventing harm. It's on encouraging the right care at the right time. It's on limiting anxiety, unnecessary anxiety for patients that results from over testing, and ultimately also has to do with sort of the what we in the economics business call transaction cost, the cost associated with going to the doctor, sitting there, taking time off, etc., which is substantial and can also be measured sort of in monetary terms. So where are we with low value care measurement today? There are about 450 measures out there by that, or categories of services that meet the broader definition of low value care. But I want to make 3 points on this before I go into detail into what we've done. The one important thing to remember, again, I want to reiterate that, is that the Choosing Wisely work originated with providers and really were owned by providers and their specialty, their medical societies, and that had a number of advantages that still hold. So you don't have a payer coming in saying that care isn't right, you shouldn't do it, I'm not going to pay you for it. That has allowed, however haltingly, the trust in the concept of low-value care to grow and to be owned by healthcare providers and clinicians. Secondly, though, progress in defining what care meets the criteria for what is not recommended has been kind of slow-moving, and the progress on reducing low-value care has been slow as well. And then largely, and this is not my perspective, but a viewpoint really shared by smarter observers than I am, the focus of low-value care measurement has been really on small-ticket items. And what that means is that there is significant work that remains to be done on real revenue generators, surgeries, and hospital delivered services. So with that, what I wanted to say is, whoops, and now my numbers don't quite show up. I had this beautiful picture of a iceberg, proverbial iceberg, of which I wanted to point you to as the tip that the 450 metrics represent, but the very tip of the iceberg are the 18 measures that we looked at in our study. So I don't want to give you the impression that we have covered the whole topic of low-value care in this first endeavor of studying low-value care, nor are the measures, the 450 measures, really getting at the meat of what is potentially wasteful care or not recommended care in healthcare today. So apologies for not being able to see that iceberg. Google provided a pretty picture. A few words about the conceptual approach that we took to this first look at low-value care. We wanted to identify outpatient services that met the categories of low-value care. We looked for metrics that were rigorous and had clinical consensus. We needed these measures because of the data to be specified, to be able to be specified in administrative data. And we also wanted to focus on the impact that they present, both in terms of system costs, but also harm to patients. And then ultimately, we also were not looking for measures from across the broad spectrum of care delivery, but really wanted something to hang together so that our audience, which includes you, but also covers broader, the general public, which kind of hangs together and helps tell a story. So we chose measures from Choosing Wisely, State of Washington, the U.S. Preventive Services Task Force, and the National Institute for Clinical Excellence. to help us. We're not clinicians and have not a deep understanding there. So to help us fill that gap, we work with clinical experts at Mayo to help us understand some of the method trade-offs and to help us interpret some of the data. So that was a really valuable and helpful partnership. And we also had the chance at the end then to share the findings and our approach with the medical community at the committee at the Minnesota Medical Association. That was helpful too. So what did we find? In 2014, there were about 92,000 encounters associated with these select types of low-value diagnostic imaging that we tested. So 90,000 times did we have non-recommended imaging. About 69,000 times did we have encounters for low-value disease screening that was not recommended, and about 15,000 times did patients receive certain preoperative tests that were not recommended by the medical community itself. In aggregate, what does that mean in terms of system costs? About $54.9 million in healthcare spending went to these narrow 18 services. And I wanted to give you some examples without going really deep into the analysis, because I have about 20 minutes to wrap up my story. So maybe three things. About $22 million were spent on head imaging for uncomplicated headache. Again, here the example is somebody presents with a headache. They're worried perhaps about growth in their brain. They say, shouldn't we do a CT? And the medical community, in the circumstances, decides in favor or not. There are guidelines to developed again by the in this case the Academy of Radiologists, to say under these circumstances CT is not the first step that you take. I'll pick a second one because it's different, both in terms of the cause and a different population. And I should say, when we did this analysis, it's very specific to population groups, to people with certain health conditions. Speaking about that, the abdominal, which one did I want to talk about? Well, the abdominal CT with and without contrast, the spending there was about duplicate spending, because typically the addition of contrast doesn't give the clinician additional diagnostic value, and that's why it's typically not recommended. I'll stop here maybe and see if you have questions about the approach and sort of the family of metrics that were chosen.
Thank you, Mr. Gildemeister. Are there any questions or comments? Seeing none, I will go ahead and make a quick comment if I could. While you're speaking, I can't help but ask, we all must be wondering, well, why would any physician engage in ordering low-value cares or services? And three things that jumped out at me. One is habit. We're taught that in medical school, and so we just continue the habit. And recommendations may change, but those recommendations may not be universally embraced. So we continue to order the CAT scan for the headache that's potentially got some flavor that it could be a representative of a bleed in the brain. At that point in time, the habit might come into play. The second one, I think, for physicians would be apprehension. I think oftentimes there's apprehension that if the physician isn't Johnny on the spot, the first one to make the diagnosis, then the second physician seeing the patient, whether it's in the emergency room or wherever, will say, well, good grief, I don't know what that horse doctor was doing by not ordering that CAT scan. He should have seen that. And so there's the jousting that goes on, the potential for litigation that occurs, the loss of professional credibility. It's far easier to be on the front end. So just in the old days, what we used to say is, order it all. When the dust settles, pick out the positives and you got your diagnosis, but that's quite expensive. And then the last one, which is perhaps most troubling and most difficult to talk about, is the profit. If all of a sudden a physician has just invested in a new CAT scan machine and the headache patient walks in the door, you can say, shoot a mile, do I want to really go deep into the weeds on taking a long history in that, or why don't we just order a CAT scan, reassure ourselves, and there'll be some profit to help pay for the machine as well. Those are some of the reasons why these low-value services, this low-value care does exist, and obviously to get at it and to try to push the snowball back uphill, that's going to be the challenging part. Any other questions or comments? Dr. Klein, perhaps. Senator Klein, perhaps.
Mr. Chair, the thoughts I had while you were speaking were that these excessive diagnostic tests and preoperative screening and so forth really are a small part of the pie. And the more concerning and certainly expensive unnecessary care, low-value care would be, say, surgical procedures of uncertain benefit. For example, a study from 2014 documented that a sham knee surgery called a meniscectomy was just as effective in pain control as an actual meniscectomy. Very good study. Now that would be if we stopped doing meniscectomies because we decided as a society that they weren't medically effective. That would not only change medical delivery in a huge way, it would save enormous costs that would dwarf, I think, the $50 million that you suggested from these diagnostic studies. So I don't think that we're getting at the big ticket items really with some of these things. You mentioned that it was helpful that these initiatives had come from the medical community rather than being sort of dictated by payer networks or the legislature. And yet, in changing behavior, very little had occurred. And I think in order to actually change behavior, we'll have to change how we pay for these things and make some tough sort of quality decisions on what our public networks will reimburse.
Calling you in that regard. The article in the New England Journal of Medicine that Senator Klein refers to identifies that there were 700,000 arthroscopic meniscectomies, which is basically when someone has a torn meniscus. And they cost $4 billion. And the conclusion of the article, and the New England Journal of Medicine is well regarded, was that if you do a meniscectomy with physical therapy or just physical therapy, your outcomes are similar. And when Senator Klein sent this article to me, I thought, well, I should do some follow-up. So I did make some calls to some orthopedists that I work with routinely. And they fully acknowledged that probably the largest area of abuse in the area or in the arena of orthopedic surgery is arthroscopic meniscectomies. And there are certain patterns that you will be able to see in terms of where you're getting the most unnecessary arthroscopic surgeries done. So this is exactly right. And the cost there was $4 billion, and I think that gets to Senator Klein's point that while this is important for us to understand, there are even larger pots out there that we somehow need to get at. And the question is, how will we get at that? So thank you, Mr. Gildemeister, for taking a break and allowing us to intrude with questions, and please proceed.
Mr. Chair, Senator Jensen, I think your and Dr. Klein, Senator Dr. Klein's comments were really helpful. I would add, in terms of the why, patients sometimes play a role as well. So they come in with worries. They've seen a study, they've seen an advertisement by a imaging company. They want certainty. Well, we can talk about that towards the end of the presentation, sort of concerning the lessons. But as patients, we play part of the role, both in terms of asking critical questions about the care that we are given or that physicians want to offer, but also to think about whether more and new is always better.
I think I've asked myself, how do we obstruct low-value care? How do we stop it from happening? And I know as a primary care physician, I oftentimes find that the most effective way for me to stop low-value care from occurring is don't refer the patient to anyone other than myself, because I know that I have a relationship with that patient and we talk a lot and things like that. It's interesting to me that I cannot recall that I've ever sent a patient to be evaluated for obstructive sleep apnea that has not come back with the diagnosis of obstructive sleep apnea, which would imply that I bat 100%, and I don't, I'm sure. So the bottom line is we have virtually everybody who's being evaluated for obstructive sleep apnea, diagnosed with obstructive sleep apnea. Once you're diagnosed with sleep apnea, then you get the CPAP machine, which is typically $5,000, and yet 75% of those machines are collecting dust within 12 months of getting them. These are the kinds of things that somehow we need to have that patient pushback. And again, I'm going to just throw one other thought out is I ask myself, how would I do it if I were an insurance company to try to get costs to be controlled? And one of the tools I would have to use, and this will be onerous for some physicians, is prior authorization. And prior authorization is a tool that will allow an insurance company to say, you know what, we can't have everybody that snores get a $5,000 sleep test, because anybody on their back, tired enough, with enough wine, will snore. And even without the wine, they'll snore. So we're wasting a whole lot of money. And so I think that it does sort of shed a new light on the concept of prior auth, which in the world of medicine is oftentimes sort of seen as Darth Vader kind of thing. But it is a tool for insurance companies to say, hold it, we have to somehow impede this process. Has the back pain been there for 6 weeks? If it hasn't been, then this, and this would be reasonable alternatives until we get to 6 weeks of back pain. Because from 0 to 6 weeks, 60, 70% of the back pain will go away and the MRI won't be necessary. Thank you, Mr. Gildemeister.
Mr. Chair, Senator Dr. Jensen, moving on, and I'm moving sort of towards the end of the presentation. One more look at costs. We broke it out into who bears the costs for these select low-value services, however low they are, and however little of the tip of the iceberg they represent. We were a little surprised seeing that much of the work has happened in this research has happened in Medicare. We were a little surprised to see that commercial payers bear more than half of the spending for low-value care, $29 million in 2014. And the other thing that was a bit surprising is that we as patients, and there's sort of a self-motivating factor, I think, pay about $9 million in out-of-pocket costs for these services. So the question is not, I think the motivator for patients ought to be not just how do I avoid harm and burden delivered through unnecessary care, but there's also a cost component that we're responsible for. And then Medicare and state public programs account for the remainder of the $54.9 million. Lessons and closing thoughts. I wanted to use the same template as when we talked about last on broader questions of bending the cost curve, and borrowed the title to ask what tools do we have to bend the low value spending curve. And again, I think you have on the side of reducing demand or reducing supply a number of initiative or tools. They all have downsides. Not everyone I like, and certainly others will not like some or all of these. But these are the tools that are available, and we sort of, as a society, or you as legislative, will think about providers, and payers will think about what creates the best mix. Patient cost sharing. There's a lot of downside to patient cost sharing. Value-based insurance design, where we don't disincentivize unnecessary care, but where we incentivize high-value care. Patient education. I'm sure Ms. Krause will talk about the 5 choosing wisely questions. The questions we should ask really for all kind of care when we see a doctor. Is it necessary? What are the alternatives? What are the costs, etc.? Provider transparency. I think transparency is important, not necessarily to choose a provider, although that there's a value too, but to understand the volume of low-value care, how we're making progress, and where there are opportunities. And I'll say a little bit more about that in a moment. And then sort of on the patient side, moderating the culture of more and new must be better, because we know that's not the case, and it leads to unnecessary use of unnecessary services. targeted pay for performance, where we sort of have a target for, say, reducing unnecessary imaging for low back pain, and we pay an incentive for those who meet a target or exceed it. Again, the literature is not really excited about pay for performance the way it's been established, but it is one tool. Selective prior authorization, committee chair was, of course, right on. A lot of downsides from the perspective of many, but it is a tool. Risk sharing, sort of this broader category of advanced payment systems, where through a contract between providers and payers, risk sharing is established, and the notion is that if money is on the line, provider systems, medical systems will look for ways to create greater efficiency. I'm a little skeptical about this as a tool for reducing low-value care, particularly for these small numbers, mostly because it's blunt. When it's all about resources, total cost of care, it's difficult to manage a lot of care delivery practices against best practices. With a blunt tool, you get a blunt reaction, I think. Dr. Jensen, was there a question? Mr. Chair?
Senator Klein.
Mr. Chair, can you speak about, I know at the rollout of the Affordable Care Act, there was supposed to be a large funding and component of comparative effectiveness evaluations to sort of control costs and ensure quality. And at a federal level, we were going to decide if X therapy was better than Y and if it was more cost effective. Has the state of Minnesota received any sort of federal feedback or data from that project that informs our decision making?
Mr. Gildemeister.
Senator Johnson, Senator Dr. Klein. Yeah, comparative effectiveness is a real powerful tool to ask, is the new technology, is the new prescription drug worth its money, or is it contributing in significant ways to the health of a patient? There's a lot of work happening in that area. It's happening at the national level and in academic settings. And the Agency for Research and Healthcare Quality, I think, has been channeling most of those initiatives. If you'd like, we can summarize sort of what we know about that area. My sense is not that it is something that we at the state level have much involvement in, or that we take advantage of much. There are some states who are a little bit more aggressive in that area. I think I would think of Washington State and Oregon, who have their own health technology assessment initiatives and have for a number of years to inform what services are delivered in Medicaid. I know Minnesota is part of that broader center of research, but beyond that, I don't think I'm enough expert to speak about that.
Thank you, Senator Klein. Thank you, Mr. Gildemeister. Mr. Gildemeister, could you just elaborate, perhaps just a moment, on some of the initiatives that Oregon has participated? You said in their public plans that they've done some innovative work. Can you just share a little bit more about that, please? Thank you.
Well, Oregon is such an interesting health policy story, and has been for many years. I think they've been ahead in recognizing that access, that health is informed or is improved by services other than healthcare, and they've invested sometimes in air conditioner and boots rather than visits to the hospital or to the emergency room. Oregon has also sort of had that history of saying we can only afford, we only have this volume of resources, and then let's decide which types of services ought to be delivered to Medicaid patients. So if they created that prioritized list of services, I think it died over time because it was really difficult and hard to predict how expenditures evolved. My reference to comparative effectiveness and health technology assessment, I think goes back to active research initiatives within state government to assess, with input from academia and clinicians, to assess what value certain services add to life expectancy, to health and wellness, and as I said, that's about as much as I'd like to share from the top of my mind, but I'm happy to pass on an email with a little bit more detail to the group.
Thank you.
Mr. Chair, Senator Jensen, moving on the supply side, clinical decision supports are probably the tool that are discussed most around reducing low-value care, and what those really are reminders, pop-ups, education that built into the EHR systems that when a physician orders a test, sort of provide the pros and cons around delivering these kind of services, sort of saying, have you thought about this? Have you thought about an alternative? And again, those are not necessarily new things, but to build them into these systems has taken time and effort. And as you were saying earlier, it's also something easily to dismiss when it's not paired with what I would argue is the second and the last item, clinical education, diffusion of medical evidence. There's a lot of medical evidence that rushes into providers to digest it and absorb it and filter it, I think is a big job. But then also to create clinician feedback where clinician leaders speak to their peers about what constitutes good care, so that it's not health policy analysts or economists doing it or payers doing it, so that, as you were suggesting, we're breaking the habit of delivering the care that we've always delivered or received. My last slide, where are we? Where are we going? What do we know? On the research and evidence side, again, I want to make absolutely clear that what we have looked at is not the full burden of low-value services in the state or nationally. There are two things missing there. Many more measures, some of them claims measures, some of them measures for which we sort of have to understand what the outcome of a lab test was, so clinical data would be necessary. But also there is sort of, as part of the full burden of care, we need to understand, well, somebody delivered a test. What happened after the test was delivered? What follow-up care happened? What kind of surgeries flowed from a non-recommended service? And how does care cascade after initial decisions were made? Really complicated area of research and fraud with sort of compound error, because we've been very conservative in specifying these measures and identifying something as low value versus not, but there's still an error in there, and you don't want to end up sort of compounding the error by traveling down that path of, well, this test actually would have been necessary, and in clinical settings, that's what we would have known had we had that data. Long story short, there's much more work that needs to be done. Cutting closer to the bone to get to those revenue generating services, surgeries, etc. I think it's really also important to understand if there are certain patients who are more likely to receive low-value care. How can we work with them? What messages work with them for them to play an active role in care use and care delivery? And then sort of the counter to overuse. I think underuse is also really a critical part of understanding low-value services. I don't know if I should share that, but a member of my family has just lost a lot of weight and is looking much better, but only after getting a diabetes diagnosis, which could have been preventable had that losing weight, exercising, changing eating habits occurred first. So understanding how to address underuse as well as communicating with patients is really important. In the practice, I think a really difficult concept to deal with for all of us is risk. What is my risk of having a brain aneurysm? What is my risk of having a spinal problem? And what is the risk of receiving care that was not necessary? So working on tools, techniques, medical guides for patients to help us, together with providers, make difficult decisions, I think is incredibly important. One outcome of our work that we've been very excited about is that one of the medical system has come up to us and have said, this is the first time we've seen benchmark data against which we can compare ourselves. So the way the market works is, I'm a clinical provider, I have a book of business with various health plans. Each health plan tells me how I do on some measures. Everything looks different. I don't really know how to compare myself against the rest of the market. So what this data and what this analysis helped was to say, here's what the rest of the market looks like. Now you know how you compare and where you might need to focus on it. So that's been really valuable to them and useful for us to understand what creates meaningful applied research on inefficiencies on low-value care. And then, of course, we mustn't forget that a big part of inefficiency is sort of that pricing, how we price and how healthcare prices drive the largest part of spending and have done so over a number of years. So we can reduce many of these services if that's our goal and reduce impact. But if price inflation stays what it is, I think we still haven't solved the solution. To your initial question, Senator Jensen, what do I know what other states have done? A couple have come to mind. Maryland has a really interesting model, but that has grown over many years of a all-payer rate system where all payers pay the same price for a certain hospital service. So you shrink variation down to a variation that is explained by risk. And on top of that, they've established global budgets. It's been, I think, a complex and challenging journey for Maryland, but they have had great successes, and the provider community seems to be excited about that. CMS has been saving money. CMS, the Centers for Medicaid and Medicare Services, has been saving money. So there has been a potential, but it's also a very radical move to sort of say, we define a price across the system, so it's not contract negotiating, but there is sort of a reference price, so to speak, and a budget, and then see how providers move within that budget. It gives providers a lot of power then to implement what they know best to manage care. So there is an upside to that. I would also think of Colorado and other states who are doing total cost of care measurement and publicizing it. Again, I think it's a little bit of a blunt tool, and one that I'm not sure if it's not paired with quality measures and measures on low-value services will really prove to reduce low-value care. Massachusetts is a very aggressive state in managing health policy. It's also a state with some of the highest costs in the nation, driven in part by sort of the Harvards and the big academic teaching institutions in the state. But what they have done is have established spending benchmarks and sort of use a four-tool tier of collaboration, partnering, research, and also accountability to understand why the state is not meeting the benchmark, and then calling out what factors account for it. The last 2 years has been prescription drug spending growth, and the states have limited tools to manage that. But nevertheless, it's been a very transparent and aggressive, as I said, approach that's been benefiting from a lot of academic firepower that lives in the Harvards of Massachusetts. And that's all I have for today. Thank you. Senator Jensen.
Questions? Senator Drahan. Senator Pratt.
Thank you, Senator Jensen. Mr. Gildemeister, I apologize for being late. I was thumbing through your presentation, and I noticed a couple of times you mentioned that fraud, waste, and abuse contribute about 30% of the cost of health care. Could you elaborate on where you see that and I'm sorry if you're repeating yourself, where that fraud, waste, and abuse is, and maybe some thoughts on where the state could step in to help reduce that.
Thank you, Senator Pratt. Please, Mr. Gildemeister.
Mr. Chair, Senator Pratt, it's not one of my areas of expertise. So I'm just an observer of fraud and abuse, of the fraud and abuse area. So what you read is what I read. The Department of Human Services has, of course, a pretty rigorous investigative services and to mete out fraud and abuse within its system, and they're working with technology and with vendors to help reduce that. I think what covers that area is things like billing for patients who don't exist, billing for patients who may not be eligible, yeah, sort of typical bad behavior. I think waste is sort of the broader category of administrative complexity that has grown over time that may not be necessary, sort of records, paper, processes, staff, that if we were to design a system from the ground up might look different and might account for less of overall spending. I talked about overtreatment as part of this non-recommended low-value care. Pricing failures is about everyone contract, sort of the counterpart to the Maryland experience where pricing failures come from contractors negotiating in private and depending on their market power, on their market power that comes from the size of their organization, where they originate, what alternatives exist, that they can command higher prices than their competitors. If prices were more transparent, I think we think the range would shrink and the overall spending on healthcare would shrink as well. Failures of care coordination are about somebody is admitted to a hospital, their doctor doesn't know about that, so there's lack of follow-up care, or rather you admitted at one facility, you readmitted at another facility, they don't have a way of obtaining records or don't know how to, or it takes too much time, so tests are repeated and care is wasted. Failures of care delivery is about not being able to see a primary care doctor when your shift ends at 8 o'clock, or having a healthcare system that is so complex that you just rather not go to the doctor because you either don't know how much it costs, or you feel that you can't afford it, or you're sort of overwhelmed and feel feel not smart and don't really know where you end up and pay a lot in the process. So those are the categories of waste, fraud, and abuse. But what I might do is share with the committee a paper that is more articulate about sort of that family of healthcare spending estimates.
Thank you, Mr. Gildemeister. Senator Pratt.
Thank you. And thank you, Mr. Gildemeister. And I sat on a no-fault insurance reform committee a few years ago that identified a number of fraud, waste, and abuse just in the no-fault insurance area. Unfortunately, we were unable to enact a number of those provisions, but kind of along that line, basically, I have a friend that says one of the best ways to disinfect a problem is to put some sunshine on it, and I see that you have provider transparency. Do you see that as a way to help maybe expose and drive out some of the waste, fraud, and abuse that are in and maybe even the pricing failures in the system?
Mr. Gildemeister.
Mr. Chair, Senator Pratt, my view on transparency has evolved over time. I think in 2008 when we passed legislation to a bipartisan legislation on healthcare reform, transparency was a big part of it, motivated primarily or in large part to empower consumers to be active participants in healthcare consumption. I think today what we're learning is that consumers are not active consumers of transparent information about healthcare. decisions we make about where to go has more to do with whether there's easy parking and what's in our network than sort of a person's quality rating or prices necessarily, in part because we as consumers don't pay the full price anyway. That said, there are two other drivers that benefit from transparency. I think one is providers themselves. As Senator Dr. Jensen has said, providers are competitive. They want to look good to their peers. So I think transparency, what we've learned from the quality measurement world, however imperfect that is that transparency helps in having a discussion around quality. So they're competitive. Sunshine helps, I think. And lastly, payers will take advantage of Sunshine in this case too, to organize their networks, hopefully around quality and not just around prices and what prices or what contracts they can derive. So I agree with you fully that Sunshine and transparency is absolutely essential. I would add, it's 2017. We shouldn't really be talking about whether it's possible to understand the cost of a certain service before we receive it, but whether or not consumers will actively take advantage of it and drive the system, there are other benefits from transparency.
Thank you.
Thank you, Mr. Gildemeister. Senator Pratt?
No, that's fine.
Senator Drahan. Senator Wickland.
Thanks, Mr. Chair. Yeah, the question, earlier in the presentation, you talked about how there is a lot of significant work that's still left to do to identify which of these low-value care areas or categories are really the most likely to produce substantial costs or are driving substantial costs. And I just wondering, who do you think is best suited to figuring some of that out? Because it seems like if we don't have the information, we see what you've presented today. We've heard from Dr. Jensen and Dr. Klein about, what an example of something that seems to be an apparent area of maybe low-value services driving substantial costs. But who would be best suited to be figuring these things out so that we have more opportunities to address this? And I know that your group could do that, but can do that. Is that something that the legislature can be tactical about funding more directly, that type of work? Or are there other organizations that we could influence as far as how they do that work?
Thank you, Senator Wickland. Mr. Gildemeister.
Mr. Chair, Senator Wickland, it's a really good and tough question. The way I would answer it is to say there's a lot of power in doctors themselves saying, we're not sure that everything we do has a good foundation in evidence and in science. Either because the science doesn't exist, we've just done whatever we've been taught, or because we're ignoring it for a variety of reasons that Senator Jensen already spoke of. So there's a lot of power in that. I think the downside about that, and the Choosing Wisely initiative has been really religious almost about keeping costs and the payer perspective out of it, to some advantage, as I noted. The downside is we've moved slowly. A lot of the specialty societies have pointed at others. So surgeons have said, well, what about imaging? And we haven't really gotten to my pocketbook. So I think the question on the question earlier about comparative effectiveness, I think is sort of one way to answer your question in saying, yes, there should be funding and support for pushing forward the knowledge base, or at least having a discussion. As I said, Washington and Oregon do something along those lines, not strictly focused on low-value care, but more broadly on looking at the best practices around, like opioids has been a big part of their research, their focus. So yes, funding is important. I think the work ultimately requires clinicians, and not just as partners, but perhaps as leaders. But if you like the model from Massachusetts, where a commission acts as I said, partner, collaborator, but also somebody who holds a stick and says, if we're not meeting these goals, there will be repercussions, whatever they are. I think that's helpful. As to specific mechanisms, we'd love to be part of it. I think our expertise sort of fits into a narrow band. I think it would have to involve clinicians, payers, medical groups themselves. And ideally, I think it would also move sort of in the arena of taking advantage of data and electronic health records to be able to get at some of the more complex clinical questions about whether a service or a procedure is recommended or not. I'm sorry for the long question.
Thank you, Mr. Gildemeister. Senator Wickland?
Just a couple of things. The Massachusetts, is that commission, is that something that's made up of a combination of private industry or providers and legislative actors as well, or is it more provider-focused and payer?
Mr. Gildemeister.
Mr. Chair, Senator Wickland, I'm not entirely sure that I remember correctly, but my sense is it's very staff and research led, but providers and payers are sort of part of it, sort of by definition, because the approach involves collaboration and partnership. But it's definitely, they're definitely willing to step on toes and require accountability from the system, health plans and providers.
Thank you, Mr. Gildemeister. Senator Wickland. Two thoughts come to mind in light of your question, Senator Wickland. Number one is, I think physicians certainly do drink the Kool-Aid with some frequency, but I remember being frustrated watching so many women equate the value of mammograms and bone density tests. And so they would oftentimes chintz on the mammogram and do that every 3 years so that they could get a bone density test alongside of it. And the Minneapolis Tribune came out with an article that was well-based in science that indicated that if you had a normal bone density test, the next one you get should be 15 years later. And that finally pushed that pendulum back a little bit so that the mammogram was given far more weight in terms of its value for livelihood. The other one is carpal tunnel syndrome. I think that there's value, as Mr. Gildemeister said, there are resources out there for patients to access, but oftentimes when they try to access it, it's a confusing picture. But the fact of the matter is, if I have a patient that comes in and has had 6 to 8 weeks of carpal tunnel symptoms and the examination is consistent with a carpal tunnel, if I share with them that 2 years after the surgery, their results and their satisfaction will be approximately the same as if they'd had no surgery. That if they go through physical therapy, wear a splint, possibly get a cortisone injection, even, if you will, receive chiropractic treatment, that their outcome at 2 years will be no different. That's when finally the patient gets off the dime and say, gee, maybe carpal tunnel syndrome isn't necessarily going to be, surgery isn't going to be the answer. So I really agree with what Mr. Gildemeister is saying, and I would advocate that at some point in time we somehow have to engage the patient in a very real way with some very real responsibility, not simply empowering them to be their own best champion, but calling on them to be their own best champion. With that being said, I want to thank you, Mr. Gildemeister, once again for your excellent presentation. And we will move straight into Ms. Deb Krause's presentation on choosing wisely. She's the Vice President of the Minnesota Health Action Group. And thank you again, Mr. Gildemeister. Ms. Krause, if you could please introduce yourself and begin. Thank you for being with us today.
Mr. Chair, good morning. I'm Deb Krause. I'm Vice President with the Minnesota Health Action Group, and I appreciate the opportunity to talk with you today regarding what the Action Group is doing in partnership with Consumer Reports and the Choosing Wisely initiative to reduce low-value care.
Thank you and welcome. Please proceed.
The Minnesota Health Action Group is a coalition of public and private purchasers whose sole purpose is to represent those who write the checks for health care. So our organization is a diverse organization of members that collaborate, and they focus on innovations, they focus on high-quality care, creating engaged consumers, and really ensuring the economic vitality of Minnesota communities. We're based in Bloomington, Minnesota, and we were formed back in 1988, so nearly a 30-year history initially as the Buyers Healthcare Action Group. So our membership is diverse, as I said. We include the large corporations, the great Minnesota organizations that you probably think of when you say who's headquartered here. Organizations like Best Buy and Target and 3M, Super Value, and many more. But we also include a variety of mid-sized corporations, so Mills Fleet Farm, Emerson Rosemont, and also, and importantly, we include public purchasers such as CGIP, the State Employees Group Insurance Plan, the Department of Human Services, Hennepin County, City of Minneapolis, the League of Minnesota Cities, and then a variety of cities, counties, and school districts. So we really are diverse, attempting to represent all of the folks who write those checks for health care. Since you may not be familiar with the Action Group, I wanted to just highlight before I begin some of the things that make us unique. People don't always know who we are, but we think four things make us unique. One is the fact that we have aligned interests. So we're an organization of members, by members, for members. We're membership-led, and those members who come to us, they have aligned interests. They're thinking about innovation, they're thinking about collaboration, engagement, and then we create key strategies that are focused to meet those aligned interests. Also, and importantly, we're independent. So we're the only Minnesota organization that represents these organizations and tries to bring a voice to them, the employers, the public purchasers, and those individuals who write those checks for health care. So we don't have any conflicts of interest. We're not a health plan. We're not a lobbying organization. We're not trying to sell something to them. We're really trying to look for common good and move things forward on an independent basis. And because we have a long history here in Minnesota, we have a lot of relationships and a lot of influence. We reach out and work with others in a very collaborative fashion, so have recently done quite a bit of work with Mr. Gildemeister and the Minnesota Department of Health, but we work with Minnesota Community Measurement, ICSI, a variety of organizations, as well as like the MMA and the Hospital Association and others like that. So, so we have a lot of relationships and influence from over the years, and what we also bring is capabilities and a proven track record. So as a member-led organization, we have a website and a newsletter and those sorts of things, but we convene groups around important topics, trying to focus on initiatives that are important to these employers. So you might say, well, what do you really do? And the answer is we do a number of things. We do an annual benefits survey so that we know what are typical benefits offered by Minnesota employers, what are the issues, what's working and not working for them. We do that annual survey. We collaborate with other community stakeholders around community dialogues and getting folks together about important issues in healthcare. We conduct educational sessions, whether that be meetings, our annual summit, learning networks to help our employers learn what they can do to impact positively healthcare. And one of the things, importantly, why I'm here today, is to talk about choosing wisely in our work with them. Low-value care is important to purchasers. If we're writing the checks for health care and 30% of that health care is unnecessary, right, it's low-value care, that's a problem, and that's a challenge and something that we want to try to tackle. And if you think about what are the causes of that low-value care, Mr. Gildemeister touched on a few of them, but number one is the patients, right? They're asking for stuff. They're asking for tests, treatments, procedures that they may or may not need, right? They saw the magical commercial on television about that new drug that's out, or they heard about their neighbor who had a certain condition and needed certain tests. So they'll go into their doctor and they'll ask for these things that they think that they might need. Maybe they read about it on an internet. So patients are part of the problem, and then the physicians are potentially performing these services that are unnecessary and potentially harmful. And that happens for a number of reasons as well, right? Maybe it's defensive medicine, maybe they're just trying to do what they think their patient wants, social media, cultural norms, the practice that they learned in med school many years ago. So all of those causes and factors, play into it. And from a purchaser point of view, we believe that it's imperative to reduce the low-value care. It will make healthcare more affordable, it'll improve the quality and the access. So that's why it's an important topic to us. Specifically with regard to choosing wisely, this initiative was, as Mr. Gildemeister said, an initiative of the American Board of Internal Medicine Foundation, so the foundation part of that organization. And they developed the Choosing Wisely campaign. It's now, I believe, recognized as a leading voice in defining what is potentially low-value services. It has a goal overall of helping patients and physicians choose the care that is supported by evidence, that's not duplicative, that's free from harm, and that's truly necessary. So you have the ABIM Foundation. Consumer Reports is then the partner of Choosing Wisely that supports creating all of these materials, right? So the specialty societies will provide the guidance on the medical aspects of it, and Consumer Reports creates all of the materials in a very patient-friendly way to take it forth and have a consumer-facing campaign. And then the action group is the Minnesota partner with Consumer Reports and Choosing Wisely here, helping spread the word, if you will, in Minnesota. So that's how we fit together. And just a little background on Choosing Wisely. It was developed in 2012, so launched in April 2012. And it initially had the support of 9 specialty medical societies. So some of the ones that you might know: the American Academy of Family Physicians, the American College of Cardiology, the American College of Physicians, College of Radiology, 9 specialty societies in that original founding group. And in the 5 years since the initiative was founded, they've actually expanded it. So there are now over 70 specialty societies and practice groups and associations backing it and helping create this very medically based, scientific based collateral. So I think the campaign is particularly valuable because it is, first of all, evidence-based. It's plain language. Consumer Reports tests it to make sure that it's understandable. They do focus groups and all of that sort of thing to make sure it's plain language. And third, and importantly to you, it's actionable. So what can I do with this information? Not just theoretically or rigorously, credentialed data, but what is actionable about this? How do you make it easy for the patient to do the right thing? And one of the things that they've created is these little wallet cards. And it's super easy. So keep this in your wallet. Give it to your mother, your neighbor, kid. And when you go to the doctor, ask these 5 questions to ask before you get any test, procedure, or treatment. 1, do I really need this test or procedure? Number 2, what are the risks and side effects? Number 3, are there simpler, safer solutions? Number 4, what happens if I don't do anything? And number 5, how much does it cost and will my insurance pay for it? Those are very powerful questions. If you just have those in your hip pocket and ask those questions, you can have a meaningful conversation with your doctor about what's appropriate, what's right to do, when it's right to wait or do nothing, and when it's right to take action. So Consumer Reports has a lot of resources. They do this actually free of charge. They invest and create this. So there's wallet cards, there's videos, there's little cardstock things, there's flyers, brochures, all sorts of things, microsites, newsletters, all sorts of tools and resources that can be used by physicians and by patients to have those conversations. They're available in English and Spanish, and they're all absolutely free to use. So, it seems extremely powerful, right? But you have all of this information, and maybe at a certain point, it's almost too much information, right? People don't know where to go, they don't know how to access it, and they don't necessarily get it on a just-in-time basis when they need to have those conversations. So Consumer Reports and the Action Group collaborated this year to create this high-value, turnkey, no-cost 2017 communication campaign to help Minnesota employees make good choices about health care. So the campaign actually originated with some conversations I was having with our members. I go out and as a member-based organization, I listen to them. What are their issues? What are their challenges? What are they dealing with for healthcare for their own employees so that we can find that common ground for collaboration? And I would typically ask them, so you doing anything with Choosing Wisely? How are you using it? And quite frankly, they weren't. Right? All of this good information, but it's on a shelf somewhere and they weren't using it. So we saw that there were two barriers. One is that there was too much, and they didn't have the time to sort through it all. And two, I mean, related to that, is their staffs were thin. They only have a small benefits department. They have so many things to do, and this just didn't hit the list of top things to do. But yet it was important. So what we figured out in terms of the solution is how could we make this easy and actionable so that people actually use it? And what we came up with was just bite sizes of information that they could use like that. So our solution was this a mini Choosing Wisely campaign, if you will. So I created 12 monthly features, right, each on a specific topic, and delivered to them, the employers, this in a very turnkey fashion. So they would each month get an email with, here's the topic, here's the introductory paragraph, here's the link to the Choosing Wisely resource, and you can put it in your newsletter if that's how you communicate with employees. You can put it on your intranet site, in your benefits website, wherever it works. But here it is in a super easy way. You don't have to think about it. You can just take action. It was all designed to be kind of timely. So in January, the first topic was January. Everyone's thinking about the new year. Do you need a physical exam? Maybe, maybe not. Here's some things to think about as whether you do that. The February one, February was Heart Month, so there's a ton of money spent on supplements, right? People are taking all sorts of over-the-counter things that they think might work, and maybe they do and maybe they don't. So it was about that. Will supplements help your heart health? We live in Minnesota, so the August one we just had was around allergy tests. When do you need them? When do you not? I think going into the fall, it might be cold season, so our feature is on, if you have a cold, do you need antibiotics? Do you need not? What are the questions to ask, and how do you think about it? So we really put all this content together and pushed it out then to our members. We kicked it off with a webinar last December, hosted a webinar, had really good attendance, and then got people to sign up for the campaign and begin to push it out. We aren't specifically able to sort of figure out what is the reach, how many people are getting this, how many employers are actually doing it. We don't have precise measurement in that area, but based upon the informal feedback we've received, several 100,000 employees are getting access to this information in this fashion. So we think it's helpful. We think it's potentially a piece of a solution to address the low-value care issue. In terms of what's the feedback, the employers have told us it's helpful. It's helpful to get it this way and to have you, sort of curate it for us. The manager of benefits for one of our member organizations, a mid-sized manufacturing organization here in Minnesota, I asked her what kind of feedback she's getting, and her employees actually thanked her for giving this information to them, which is pretty impressive because if you know the world of a benefit manager, they don't very often get thanks. They're usually getting feedback on the deductible or the cost or any different thing, and it's often negative feedback, but she got thanks for promoting this. So we are pleased with the feedback both from the employers and from the employees. The Action Group has been collaborating with Choosing Wisely for a number of years now. For example, just this spring in our annual leadership summit for employers and other professionals, we had a panel on this topic, and we featured Mr. Gildemeister, we featured the Director of Partnerships from Consumer Reports, as well as a physician on a panel just to talk about helping attack the problem of low-value care. So we're working to educate in various different fashions and integrate this communication and the Choosing Wisely campaign into our newsletters and various other mechanisms that we have. partnership, it's important to note that in the early days, our partnership with Consumer Reports and how we got involved with them was really a grant that we got from the ABIM Foundation through the Robert Wood Johnson Foundation to advance Choosing Wisely in Minnesota, and it was a two-pronged campaign. The action group was selected to help get it out to employers and to employees, and ICSI was selected to help get it out to physicians and patients. So recognizing one of the things that's very important to us is really nobody can do this alone. We each have our networks, and each can be part of a solution as we try to attack the important problem of low-value care.
Thank you, Ms. Krause. Are there any questions? Senator Rosen.
Thank you, Mr. Chair. And Ms. Krause, what are the next steps for Choosing Wisely? Where do you go from here?
Mr. Chair and Senator Rosen, we are very pleased with the reception that we've got from this, and we intend to continue our partnership with Choosing Wisely and working through employers to get this out. I think to the extent that we can magnify our voice even further and expand it, then I think there's potentially greater impact.
Thank you, Ms. Krause. Senator Rosen.
Thank you, Mr. Chair. Ms. Krause, so how do you measure that you're effectively getting to the employees, and is there a measurement set up? Is there going to be a measurement set up?
Ms. Krause.
Mr. Chair and Senator Rosen, that's a great question. And as I indicated, our measurement at this stage is pretty informal. It's the feedback that we've received from the employers and the employees and the general reach that we have. I think going forward, we can identify more specific ways to measure and collaborate in that fashion.
Thank you, Senator Rosen. Other questions? Senator Pratt.
Thank you, Mr. Chair. This is the second time this morning I've seen a discussion on low-value care and the idea that the consumer is going to make that choice. My concern is that you've got a patient in the room and you offer it to them and you go, well, you could or you couldn't. They're going to take it, right? They want to be safe. Part of this, I think, is being driven by litigation. It's cheaper for doctors and insurance companies to pay for a low-value test than defend themselves when something does go wrong and some prosecutor looks or some attorney looks at a doctor and said, well, gee, why didn't you give this test? Any thoughts, I mean, other than just the consumer aspect, any other thoughts around how we can get our hands around this idea of low-value care and try to squeeze as much of it out of the system as we can?
Ms. Krause.
Mr. Chair and Senator Pratt, I think that's an excellent question. It can't all be on the patient's responsibility, but the particular services that we're talking about have been identified as low-value care. So these are things that are not needed, and where there is a consensus among the specialty societies, the practitioners who are experts, that it is an area, that's potentially not necessary and could be harmful. So. There are other areas where a test may be needed and maybe you don't know and you should do it. But these ones particularly that we're targeting here and empowering them to have a conversation around are identified as low-value care options.
Senator Pratt.
Thank you. And wouldn't that be better controlled by the Licensing and Standards Board rather than the legislature?
Ms. Krause.
Senator Jensen, Senator Pratt, I actually can't answer that question. That's outside of my scope. But it's amazing. I mean, you would think this can't be that big a deal, but you would be amazed to know how many things have not been performed because patients have taken the time to ask these questions. I was speaking with a colleague, and they went in, and I don't know, they had some arm pain or something like that, and they asked the doctor, well, what happens if I do nothing? You know, the doctor was recommending a test, and they said, what happens if I do nothing? Well, nothing. We're not going to do anything different. Oh, well, then I don't want it, I don't want to pay for it. I don't want my employer to pay for it. So it's amazing. You would think that it's super hard, but it isn't necessarily that hard to ask those basic questions and then receive the candid answer and be able to make a decision based upon that. It's impossible to make patients experts on all these medical conditions, and honestly, if they try by reading on the internet, they won't get there either. But those quality conversations can make a difference.
Thank you, Ms. Krause. Senator Pratt.
I just wanted to say thank Thank you. It's out of my scope, too, so, and I've tried looking it up on the internet, and I get more confused, so thank you.
Thank you, Senator Pratt. Ms. Krause, thank you very much for your presentation. Any other questions or comments? I would simply say this, that oftentimes in the office, in an effort to be funny, I've oftentimes told a patient, if we do this, you'll get better in about a week, and if we don't do anything, it'll take about 7 days. And sometimes that's not readily appreciated for what it was intended to be. So I've actually using that comment less. So thank you very much, and we appreciate it. That Choosing Wisely program has great potential. I think the one thing you need to kick around is how you can expand your reach. Are you able? You certainly are getting to employees through your program. How are you getting to the individual marketplace? How are you getting to the public health programs? Things like that. So please maintain a dialogue with us if you would. And thank you again.
Thank you very much. I appreciate the opportunity to talk with you, and I'll actually leave a supply of my cards on the back table if anyone wants to take one. Thank you very much.
Thank you again, Ms. Krause. And because we are slightly behind schedule, but not too bad, we're going to go straight into Ms. Shawnee Christenson's presentation, along with Ms. Heidi Mathson. They're from the Minnesota Association of Health Underwriters, MAHU, and they're going to talk about essential health benefits. And this is, again, one of those critical areas. And if I could once again reiterate, any focus or inclination you can get for us on actionable items and things that we can actually do so that we can move forward on this bending the cost curve downwards. Thank you again, Ms. Christenson and Ms. Mathson. If you would, please introduce yourselves and begin. Thank you.
Good morning, Senators and Chair. My name is Heidi Mathson. I am an individual insurance broker. I own a small agency in the metro area. I work with consumers on a daily basis choosing their health insurance and making health insurance choices.
Good morning, Senator and the committee chairs. My name is Shawnee Christenson, and I as well own a small agency. And today we're representing MAHU, and needless to say, we're meeting with people on a regular basis. Thank you. Okay.
The Minnesota Association of Health Underwriters is an industry group of agents and brokers and industry professionals, and we all work in the area of helping people choose their health benefits.
Thank you.
Okay. And so today we're just going to address a little bit about the essential health benefits under the ACA. We'll talk a little bit about 1332 waivers and jump right into kind of some of the stuff that you're looking for. For those of that you don't know, I did include a handout that includes Minnesota's state mandates, and it's quite extensive of what we've had in the past before the ACA was actually put into place. There was actually, I think I counted 57 Minnesota state mandates for benefits prior to the ACA. So a lot of the things that were brought via the ACA as far as mandates were actually already being taken care of here in Minnesota. There's a couple noteworthy ones though. So specifically, the delivery of children, for example, Minnesota did not cover prior to the ACA. And then there was also mental health. So those were, generally speaking, benefits that people opted into. And prior to the ACA, you saw kind of an uptick, actually, on plan designs prior to, especially in the individual market, where those benefits were actually carved out and consumers were purchasing plans without mental health and substance abuse coverage and buying coverage without the coverage for delivery. Now, prenatal coverage was always covered, but the actual delivery of the baby that day that you go into the hospital is the part that wasn't covered on some of those. You'll find a little bit as far as like the group benefits component of things. Those plan designs didn't necessarily have that same uptick, but I think part of that is because of the consumers choosing versus the employer choosing for the masses. So as far as the essential health benefits and the mandates being covered, I do want to point out that it is a little bit controversial. And so the reason it's controversial, you can probably understand, is that we understand that the carriers only have a certain profit margin that they're eligible to even make outside of actual paying out claims. And so anytime you're adding in an upfront initial coverage, needless to say, that gets passed on to the end consumer. There really is no other avenue for those expenses to be placed. So I don't know how much everybody's reference point is of the ACA and what those essential health benefits are, but I did kind of just want to point out that there are 10 required benefits. For the purpose of this committee, I don't know how much in detail you want to go in those, knowing now that most of them were covered prior to the ACA. So I want to hand it over to Heidi a little bit to talk a little bit about the Section 1332 waivers.
Sure. The 1332 waiver process is a way for states to be innovative with their healthcare design, but they do still have to follow boundaries. So you can't completely eliminate the Affordable Care Act through a waiver program. You still have to follow the basic tenets of the program. You can eliminate certain things, and you're not allowed to touch other things. So the things that can be waived would be the individual mandate, would be the employer mandate, would be having a state exchange and actually a certification process for qualified health plans. And there can be some modification to the benefits and subsidies. What the boundaries are is that you can't affect enrollment, so you can't create a waiver that would cause less enrollment than prior with the Affordable Care Act. You also have to maintain coverage that is at least as comprehensive as the Affordable Care Act. It also has to remain affordable for people, and it can't affect the federal deficit. So the waiver program, Minnesota has actually been a leader in terms of that. I believe we are the only state that has filed more than 2 or 3 waivers. I think we have 7 waivers that we have legislatively proceeded with. So we are a leader in that program and in being innovative. They're all in different various stages of approval and sitting with CMS right now, but we have definitely taken advantage of that program far more than other states. In terms of like other states that are comparable to Minnesota, Michigan is one that is kind of taking advantage of some of the 1332 waiver options to be able to affect the coverage in their state.
Question, please. Ms. Mathson, in regards to the entities that you have that can be waived, could you just elaborate briefly on the number 4 where you talk about exchanges and QHPs, and then if you would intersect that with number 2 on the next slide on comprehensive coverage, where you talk about the waiver must provide coverage that is at least as comprehensive as coverage offered through the exchange. What's being offered through the exchange is impacted by the QHP. So if you could just help us understand, because I think one of the basic questions that we are fielding with our constituents and residents of Minnesota is the whole issue of, gee, it seems like we're providing a Cadillac health plan and it's just not affordable. So is there an option to provide some sort of a stripped down, life-threatening, catastrophic, bare bones policy and then let people choose and purchase on top of that? Could you elaborate on that, please?
Right.
Thank you.
Shawnee, could you actually talk about the catastrophic plans?
Yeah. So Senator Jensen and committee, so there is actually something in place already called a catastrophic plan. So I think most people are familiar with, the what we used to have platinum plans, but platinum, gold, silver, bronze, and then there were catastrophic plans. These catastrophic plans were designed actually for people under the age of 30, or you're also eligible if you can show that there's financial hardship where really you can't afford anything else. And these catastrophic plan designs are already a little bit skinny down. And I say that in the aspect that a lot of those essential health benefits, although they're still mandated to be covered by the plan, they aren't required to be covered up front. So for example, you may have to meet your deductible and your out-of-pocket max before it's going to cover, for example, that, well, it's not necessarily in the state of Minnesota, most of them still have our preventative benefits because we still have to follow those guidelines. But specifically, it's going to cover those essential health benefits after your deductible is met. Does that make sense? So it's one way of stripping down those plans, but again, it's not eligible for everybody to even purchase.
And
Could you comment on how much that product has been purchased by various eligible persons in Minnesota?
Well, there is a demand for those products.
Are they purchasing them?
There are a lot of people like in their 30s, 40s, 50s that feel that they're very healthy and don't want to buy a plan that is loaded with a lot of front-end benefits. They want to buy that catastrophic type of plan because it reduces their premiums. And that's what's more important to them is the monthly budget, for monthly premiums. So they want that type of plan available to them. But right now, it isn't.
The other thing that's noteworthy there is that the catastrophic plans, if somebody opts to purchase a catastrophic plan, they're not currently eligible for an advanced premium tax credit on that premium. And so as a result, even though somebody may say, oh, I want that catastrophic plan because it's $50 less expensive, it may now preclude them from being able to get their tax credit. And so ultimately, they end up having to buy the more comprehensive plan to save the $25 that they might have saved with their tax credit. Does that make sense?
Yes, thank you. Please proceed.
So I would say that that's one way. I think that there's also avenues where people could buy supplemental type plans, like different indemnity type plans. So if we could get the difference as far as premiums from, like a comprehensive plan that really might not give them the benefits that they're looking for up front, if they're able to buy some sort of an indemnity plan to help fill in some of the initial coverage that they're looking for, that also I think could be an option, and I think that there would be a market for that as well. The difference would be is those type of plans would likely involve some sort of underwriting. And I look at that as part of a consumer protection, right? So I think everybody gets the idea that you can't buy house insurance, right, when your house is burning down, right? I can tell you that I've had 2 instances in the last week and a half where I've had people come into my office and say, I need insurance. And we kind of dig in a little bit, and the reality is the one person has been completely uninsured and just didn't feel like they needed it till they found out their wife was pregnant last week. So now they want to buy insurance. The other individual, turns out she had a hospital situation in June that now they're trying to collect on her, and so now she wants insurance. In her situation, she'll likely be in some kind of a, she'll probably likely still get some assistance from the county. She just didn't know where to begin, is where that one ended up. But so I think that those indemnity type plans really would be an option, but it is noteworthy that it does put some sort of an underwriting component in there, whereas if you already have cancer, you're not going to get coverage on that cancer. And the idea would be is that they need everybody paying in when they're not using it in order for insurance to truly work. And so because some of that's been completely eliminated, unless we're able to get some sort of that protection for the people who are being responsible and paying back in, we may not.
Thank you, Ms. Christenson. Senator Wickland.
Do you have an example of a state that is offering these types of plans, the catastrophic plans and indemnity plans and you could point to it as an example?
That are already using
Right.
them? Well, part of the difference is right now is that the prices in regular insurance are so crazy expensive that there just isn't being much penetration, because it's just, the premiums are so expensive in the insurance side of it that they don't have any excess resources to spend on that type of a plan that might give them, some upfront coverage for some additional preventative services that aren't necessarily mandated, and some of those additional.
There are products like that on the market, but they're not being paired with catastrophic plans. And
Senator
that would
Wickland.
require a waiver.
Thank you, Mr. Chair. In the market in Minnesota, are you saying that they are, or in other states? I guess that's
In
what-
Minnesota as well, there's some similar versions to that, those plans.
And I guess when those are offered and would be, if they would be taken up by consumers on a, larger number of people purchasing those plans, has there been any study about what that does to the rates of other plans? I mean, if those people are leaving current insurance plans and they're purchasing these plans instead, what impact does that have on rates?
Ms. Mathson, Ms. Christenson, please go ahead and answer.
So I would say that I don't think, the way the plans are designed, I don't think very many people are going to just purchase that alone without some other sort of catastrophic coverage, is what it boils down to. The people that might do that aren't buying insurance already.
I've seen them paired with like the HSA types of plans, where people would buy the plans that have the higher deductible and then would purchase some type of supplemental cancer policy or accident policy to accompany it. And those types of plans just pay for those certain types of events. They're not quite as comprehensive as some of these new plans that are kind of in development.
Thank you, Senator Wickland. If I could perhaps piggyback on Senator Wickland's question, not trying to hold you to precision, but if you could just give us, say, a 35-year-old male who wants to buy a silver plan on the exchange, but doesn't qualify for an APTC, the advanced premium tax credit. What would the cost approximately be out of pocket in terms of premiums and deductible for an equivalent to a silver plan for that person versus if that person had access to buying a bare bones catastrophic policy? What might because my understanding has typically been that a 35-year-old buying a silver plan would probably be somewhere around $5,000, give or take, I guess. How much would it be reduced if they didn't have to have a silver plan that had all 10 essential benefits in it, but instead were able to buy a bare bones catastrophic policy, and then they would choose to pay for their tetanus shot or their sinus infection that they go to a quick med for or whatever? Can you help us understand that a little bit, please? And thank you.
Well, I'm thinking back to, there used to be products, like I mentioned prior to the ACA, that did, in the individual market, kind of have those models. And that example, I would guess, was probably $45 premium difference, where in that scenario, right, the plan design gave an individual up to 3 office visits for a copay. It had roughly a $4,000 deductible, an out-of-pocket max, but it didn't cover the delivery of children, for example, and it didn't cover mental health. An individual would save about $45 a month.
In today's world, though, with a silver plan versus a catastrophic plan, you're probably talking significant savings, probably at least a couple $1,000s a year in premium savings.
Thank you for that last comment, Ms. Mathson. So essentially, if a person were purchasing a $5,000 plan of some sort, and it was the more typical plan today being sold, such as a silver plan, if they were able to find and purchase a catastrophic policy, there might be a savings of $2,000 over $5,000, which could be 40%.
Right.
Okay. And my understanding also, and perhaps I should know this for certain, but I don't, is that Minnesota has not specifically applied for a 1332 waiver to allow us to do that kind of thing.
No, not that specifically.
Are there some states that have specifically applied for that ability to offer a catastrophic plan that might provide the kind of 40% savings we're discussing?
No. Most of the waivers that have been submitted up to this point, and I could get you them. It is in the link of the digital copy of this, but it does list out all of the current 1332 waivers specifically. But most of those 1332 waivers are all geared towards either reinsurance and kind of like emergency type components, funding. So nothing quite as innovative as this. Again, Michigan really is the state that's working on similar type stuff that this committee is working on to try to move and lower the cost curve.
Thank you very much. Other questions? Thank you very much, Ms. Mathson. Ms. Christenson, if you'd like to, please provide any closing comments. Again, inclining your comments towards actionable items for this committee to consider so that we could seriously engage that kind of discussion in the 2018 session. Please.
Go ahead. Well, I would say that I would encourage us to consider, although the idea of a pre-extra waiting period is often frowned upon, I think that when you look at the real logistics of it and the consumer protection of having some of those, that's helping to compensate and make the whole system work for those of us that are being responsible about buying such programs. So I would encourage you to be a little bit more open-minded about that component of things and how, even though these indemnity type plans may have some sorts of wait periods and such for people who are buying them before, that cancer, for example, would be covered, I would encourage you not to think of that as a negative thing. I would also say that some of the other states, and we kind of heard a little bit of a reference towards it as far as reference-based pricing. I think Iowa, for example, is a state that they're coming out with plan designs where, similar to Medicare Advantage private fee-for-service plans, and those are plans where basically the contract just said, you must show your card to the provider before you receive services, and if they accept those services, they agree to XYZ pricing, and to abide by that contract. We are starting to see more of those type of plans where it's like 140% of Medicare pricing, and so that's starting to come about in some of the other states as well. That might be a workable option as well.
Yeah, I agree. Yeah.
Thank you again for presenting, and please know that the Minnesota Association of Health Underwriters is perceived by many legislators as an organization that can provide very meaningful information for us, partly because you see it from both sides, and you're engaged with both the systems, the patients, the carriers, and things like that. So please stay engaged in the dialogue, and thank you very much for presenting. At this point in time, we'll move into Dr. Bob Geist's presentation on family medical accounts. And I think we're right on time, or perhaps a little early. Thank you again. Dr. Geist, Representative Gruenhagen, thank you for presenting to us today. And please introduce yourself and go ahead and begin. Thank you.
I'm Dr. Robert Geist. I was a physician practicing in St. Paul for about 40 years and retired a number of years ago. I want to point out that the big bulk of slides that you have in your possession, over half of them I'm not going to talk about now, but they're there if you want to.
I'll help you find your PowerPoint. I'll help you find your PowerPoint.
Oh, good.
Yeah, I have.
You have to find the PowerPoint. And there are two slides that I'm going to want you to follow the animation because they're quite complex. You see it?
Yep, it's opening.
Oh, good.
Perfect. All right, there you go.
Okay. I'm happy to have Representative Gruenhagen here today with me. He is the sponsor of the bill in the House. The family medical accounts, here we go. Family medical accounts are money on a debit card for Medicaid families for outpatient care. That's all, for outpatient care. FMAs are not an account-based HSA policy. They're not insurance sponsors. They're not insurance vouchers, and they're not managed care. What I want to talk about today is your job is about cost and access. And will FMAs help reduce cost and access, reduce costs and open more access? I think it's probable, as we'll soon see. Can a family managing its own money for care help restore its market equity and self-esteem? I think very definitely yes. These will be folks who will have money at the clinic door just like their richer cousins. And our FMAs are a new mode of payment. Well, it's not a new mode of payment, but it certainly is unique to Medicaid. Now, what I want to discuss today, and we're gathered here today because there's a long history that got us into problems with cost and access. And I'm going to go through some of that because what's important to understand, medical cost price inflation became unrelenting only after 1965. For the 90 years preceding that, inflation in medicine over the ordinary cost consumer price index was almost negligible. I am not going to talk here about the Medicaid alternative scenarios, which I see coming down the pike, which you will probably do, and we can talk about that if you want. I'm not going to discuss that right now. I want to be going directly to the FMA program itself after we go through the background, and we want to see who's eligible, how much money to put on a debit card, for example, how does the program work for an enrollee, and how would it work for the plan for everybody in the state. And can the FMA program achieve a better working Medicaid system? I think it's probable. I'm not going to promise anything. And can we get beyond the fantasies of managed care cost control panaceas? That's what we've had, and I think it is not working. That's why we're here. So I think, why not? I was very happy to hear about choosing wisely. Somebody understands that doctors and patients can choose wisely. Unfortunately, there are people who think that they are the cost culprits, both doctors and patients, and that they have to be therefore managed. I disagree with that. I'm glad to hear about, I guess they're gone. I'm glad to hear about choosing wisely again. Now, this is a slide I want you to maybe follow the animation. If you look at the slide, you'll see that the consumer price index for medical services went up 17-fold in the last 50 years, and the ordinary consumer price index only increased 6-fold, 2.5 more times for medicine. Well, what happened? As we already noted, for 90 years before 1965, there was hardly any cost inflation. And that was when there was free market, very little health insurance, which we certainly do need, but there was very little at that time, mostly cash payments. Then in 1942, to get the war workers, and you're familiar with this, you get war workers into the factories when there was a price freeze on wages, they had to do something to get them in, and they decided to give them a free health care insurance. That's how the employer-based system got started, as we know. And this did not result in inflation. It started to take off a little bit, and you can see on the curve down there after 1960, there was a little edging up of the inflation rate. Then in 1965, we passed Medicare and Medicaid. And what happened at that time was a tipping point in time when 85% of the population actually had tax-subsidized insurance. Insurance was very cheap relatively by that factor. And because of that, we had a sudden onset of demand inflation. In other words, it looked to be cheaper to buy health care with insurance than it did with money. After all, the boss did pay for it, or the government. That was the mindset. That was our piecemeal national health insurance program at that time. Now, what happened with demand inflation was pretty simple. You got inflation with called a 7% cost crisis, in quotes. What was the response? Politically, the employers were very upset with this going on because they felt they were paying for care. Actually, they were not. As we know, they simply takes out of the take-home pay of the employees. But they could have repealed the tax subsidies, that would be political suicide. And so they decided to ration care to the free access, the parent-free access. Nothing's free in life. So they passed the HMO Act in 1973, which gave these corporations unparalleled power to control the benefits they insured. If you know of any other casualty company who has that power, let me know. The only ones I saw recently might be the people who replace windshields in Minnesota. I'm not sure about that. What happened was nothing. Inflation was unrelenting and terrific. The premium rates were at 18% inflation rate by 1988. This sent a real panic through everybody. People who considered themselves the purchasers, if you will, the employers and the governments. They said, let's put our employees and our clients into HMOs. Maybe they can do something. And indeed, as you will soon see, there was a dramatic change in what happened after the HMOs gained almost full control, about 90% control of the market. Take a look at 1988, when you had an 18% inflation rate in premiums, and it dropped down to 1% to 2% after the HMOs took charge. In other words, if you want to do something about cost control, just let them loose and don't do anything about what happens otherwise. What happened otherwise was the public became extremely upset and hostile about the HMOs. They wore the black hats because there were drive-by mastectomies and drive-by deliveries, which were the headline problem, but there are all sorts of other barriers to care. After all, they're there to create barriers to the apparent free care. They did their job. Then something happened in the mid-1990s. There was a movie called As Good as It Gets, and Jack Nicholson's girlfriend vilified the HMOs up on the screen, and audiences around the United States raised out of their seats, cheering her on. The guys wearing the black hats realized they had problems, and legislators in the states, not Congress, but in the states, started to pass patient protection laws. This was a real signal. The wraps were off, and the inflation rate increased up to 2003 to 15%, as you can see, and it was going north. Well, something happened then. Congress passed a law saying we'll have high deductible health plans with HSA for paying for the deductible. The total cost, by the way, of the two was equal to the total cost of the HMO. With the competition, the inflation rate of premiums went down to between 5% and 6% nationally. And in Minnesota, it was dramatic. The HMO increase was only 3% or so, and for the high deductible health plans was less than, was minus 5% inflation rate. I think this probably shows what competition and price sensitivity for premiums can do. Now, I'm not going to talk about the four alternative scenarios. I'll leave that go. For now, yes, Senator Jensen.
Thank you, Dr. Geist. Yes, I think you've set the stage, and we certainly see where the both the cost and utilization and inflation has occurred. Could you, at this point in time, move into more of the details so we understand how the FMA would actually work and how it might be implemented into the state of Minnesota were we to move forward with that? Thank you.
Right. I'm skipping right to slide number 11, as a matter of fact. So we're going right to 11 now.
Thank you.
So this is the FMA alternative, which I call the saintly alternative, if you will. And who's eligible? This will be the childless adults and the families with children. Those not eligible are the disabled and the elderly dual eligibles. The eligible are about 83% of the population, and they spend around 40+% of the money. How many dollars to fund the debit card? Now, this is where my fuzzy math comes in. First of all, I can tell you for sure what a childless adult cost in Minnesota in 2016. It was $7,992. I cannot tell you what a Minnesota child costs in Medicaid nor a Medicaid adult charge in the family with children category what an adult costs. DHS cannot tell me that figure. So you're stuck. So I simply went to what CMS, the feds say they spent on children and Medicaid, and that was $3,400 for an adult, about $5,400 for an adult in Minnesota, as we know, is $7,900. So we elected to put in the bill that will fund the debit card, pre-fund it for the children, $1,500, the adult, $2,500 for the Minnesota adult, which we know is $4,000. Now, that's the first funding. After that, we'll see what happens and then put a percentage on what they'll be funded with, and we chose 50% of what the actual costs are. That might mean these pre-funding will go up or go down. I might add that an adult who's perfectly well spends about $1,305 a year for health care. You can see $2,500 for an adult here is about twice that. So I think it takes care of the Medicaid population comparatively to a well population. How does the system program work for the enrollee? Now, let's say you're a patient and you're an enrollee, and you go to the clinic where your charge is $70 on the average, but you get a couple of other tests, and your total bill is $100. You will pay $26 on your debit card for that. Clinic will be paid that $26, and that's because the state rate is 26% of the $100 fee. That's by law. Now, let's say you go to the ER and you're not admitted, and you run up a $2,000 bill. Your card will be nicked for $300 because the maximum copay is $300. After that, the state picks up the balance, and the clinic, in this case the ER, gets its total pay of $520. How does this work? And this is one slide where I think it'd be valuable to follow the animation. First of all, what we do now is we have an HMO box, and we put the patients in it, we dump the money in afterwards, and then kind of hope for the best. Problem you're here with is that the costs continue to escalate. Now, what CMS found in 2012 about the overhead of these HMOs and Medicaid was around 11.6%. That was down from a previous 23% that they thought in 2003. Then Connecticut came along and found out they had the same problems we had. They couldn't find out where money was being spent. And they ended up firing their HMOs after they found the overhead was 12%. So, and then reduced their total cost of their program to 5.2%. Anyway, we thought, well, okay, can we do something better than this? Let's take the first dollar money and put it on a debit card, and the patient goes to a clinic or the ER, and the card gets swiped, just like you go to Cub Grocery to buy a bottle of milk, if you will. The banker is the DHS. They pay the bill. They are allowed in the bill, if they want to have a private bank involved, but they are also mandated to have an independent third-party administrator to coordinate all of the accounts. Now, I might add that the card, there's a freebie on certain drugs and procedures. For example, preventive services are a freebie, and the definition is a federal one. The drugs that are excuse me, I'm just getting over a cold. The drugs are for blood pressure, diabetes, and epilepsy, and so forth. There'll be a couple of added after conversations with the community doctors and the community clinics for the Medicaid population. But the question now is the overhead going to be reduced down to what it is in the private sector for large populations of 1,000 or more? That's 5 to 8%. Presuming that our overhead is about, like has been reported elsewhere, of 12%. By the way, I cannot find out what the Medicaid overhead is here except for UCare in Minnesota. I think the other thing that might be helpful is not only reducing the middleman overhead with this program, they're out of the picture, but the empowered families prudent family who is lucky to not have ill health will certainly have money at the end of a year to be rolled over, significant money. And the, excuse me. And I think this is most important. If they run out of money on the debit card, not a problem. The state just simply picks up the bills from there on. In other words, it's a no-lose program for the enrollee or for the system. It's just another method of payment. What might be the potential benefits then for everybody, patients, doctors, the public, and the Medicaid program itself? There's some corollaries when you empower families with money. This means you get open counter payment data with the TPA that's mandated. DHS will know where the state's money is being spent, and they can focus their care on the chronically ill, needing more community resources. The bill will call for that to be coordinated, by the way. Connecticut program has set up an excellent paradigm for this the state can follow. The UK has interestingly got together personal health budgets for their very high-cost patients, over 15,000 pounds or some over 20,000 pounds a year, and this could be applied to any part of Medicaid in Minnesota. But there are a few disabled people and children, families with children, which this could apply. There'd be transparency and access. You can compare the two programs, the FMA program, which they have a free choice to take, compared to a free choice to take the HMO program. We can compare those two systems, if you will. Connecticut, by the way, found that when they increased the pay for doctors, you'll be interested in that, certainly, they found that without the HMO barriers, if you will, that the participation rate of the clinics went up over 20%, and that meant patients were going not to the ER first choice, they were going to the clinics. A remarkable change, I thought. I want to make sure you understand the cost problem in medical prices is not medical prices, but it's administration costs. And I think the Connecticut experience emphasizes objective evidence of that. I'm going to skip this slide about payments to the PMAP program to the HMOs compared to doctors. Just notice at the end of the slide that the doctors' pay, especially specialty groups, was falling off a cliff, whereas the HMOs apparently were doing quite well. I just want to point out one slide that showed the administrative cost growth rate and the share of spending growth rate are the high rollers, if you will. As you notice, physician service prices were a low growth rate, if you will. So in conclusion, an enrollee will have a free choice of the FMA program or the HMO program at enrollment time. They'll have free choice of providers. It's a willing provider to take 26% on the dollar. And their access will be open because they have money on a debit card to go where they will. Now, of interest, the commissioner is mandated to publish monthly the locations and ordinary prices of clinic procedures and clinic visits, and that is unique. FMAs are patient-owned healthcare research. That's money for outpatient care. And that is unique. The TPA is a debit card exchange. It's middleman overhead it's eliminated, and I think will be the biggest cost saver for the program. Finally, you're going to need a waiver, federal waiver, 1115 waiver, if you're going to do an account-based program like this. The premier, or I should say the paradigm account-based program is the one in Indiana called HIP 2.0. It's called an HSA program, and has a waiver going up through 2018. The problem is with this program is it's extremely complex administratively. Patients have to pay premiums, which are income related, and they're punished if they don't pay. That is, they lose mostly it's vision care and dental care, which it seems to me might be very important for children, which are a majority of the patients and families with children. And the percent rollover, to show you how it doesn't work as an HSA, is extremely low. They only can get back what they put in on their monthly pay of either $1 a month or $27 a month, and that adds up to a rollover at the end of the year if they spend nothing of their $2,500 power account. Remember, that account is just about what the FMA account is for an adult. But if they don't spend any of that, they get to roll over between $12 and $324. I don't know where prudence comes in. What's very interesting about this program is the Kaiser Family Foundation report last year showed that of the 6 account-based programs in states that are seeking waivers, including Indiana, which has one, that they seem to be completely ignore a goal of saving money. Very interesting. The administrative cost of those programs, I think, is extremely high. On the other hand, my saintly family medical account program is not complex. There's no premiums, contributions, they call them elsewhere. There's no punishments. There's no managed care barriers. You got a card, you can go where you want if it's a willing provider. It's unlike the ACO gatekeeper system where the doctor gets paid more for ordering less and gets paid less if he orders too much by the corporation. Real possibility of rollover money could be a bridge out of Medicaid. I think there will be rollover money. Patients who are lucky enough to stay healthy and who are the least bit prudent. Now, can we make Medicaid happy again? Here's a picture of it being signed back in 1965 by Lyndon Johnson. Here's Lady Bird looking over her shoulder. Harry and Beth Truman there sitting there. And in the background, I want you to notice a familiar face. That's Hubert Humphrey, one of the people I think was one of the greatest men in Minnesota history, but one I very much admired. I didn't always agree with him on things, but I certainly admired that man. So what's your take home here? FMAs are a method of payment. That's all it is. There's nothing to do otherwise. I think it's the best way to contain costs. I think it's the best way to get access freedom, which is what this committee is about. It can be used for any single-payer program. After all, Medicaid is a single-payer program. And it can be used, I think, as a paradigm in other states once it gets implemented. Allows for monitoring utilization costs and illnesses with the TPA administrative data. And I think, again, Connecticut has shown a paradigm of how to handle that very nicely. Federal waiver is going to be necessary. Will they look kindly on actually giving money to people on Medicaid? I don't know. I hope they will look kindly on that. I think it's a good way to go. Then we get beyond the advantages of managed care cost control through barriers to care, panaceas. These are rationing systems. They haven't worked for 5 decades. They haven't worked in Medicaid for over 2 decades, and I think it's time to change. Why not? Thank you very much.
Thank you, Dr. Geist. Any questions from the committee for Dr. Geist? Representative Gruenhagen, would you perhaps provide some thoughts that you have and perhaps some summary
just a couple
comments?
brief overviews. I know we're the last testifiers before we adjourn, so we'll keep it to the point. One of the reasons I signed on as the chief author is because I firmly believe what our former state demographer report showed under Tom Gillespie, that the demographic changes are going to drive huge changes as far as healthcare costs in our state. For those of you who haven't reviewed that report, and again, Tom has retired, but the report, I think, still carries validity. He basically said in that report, if we don't get the healthcare cost in this state under control, there will be no additional money in the future for roads or bridges, higher ed, or K-12 education, okay? That's the report. So one of the things that has to be reformed, that is growing at a rate that is not sustainable, is our Medicaid coverage. So if you want to reform health care and address some of these things that are in here, Medicaid reform is the linchpin, one of the primary linchpins of reforming our health care system if we want to continue to have the access and excellent health care we have in the state. In the last biennium budget, for those of you who paid attention, our total spending went up between 9 and 9.5% on our biennium budget. The private sector in 2016, 2017 was projected to grow at 3%. So the people paying the bill, they're growing at 3%, but state government's growing at 9 to 9.5%. Now, I don't know about you, I can't grow my expenses faster than my revenues in my personal life and my business. If you can, let me know how that's done. The point is this, of that 9 to 9.5%, 5% was due to Medicaid growth. So over half our growth in the state budget was due to Medicaid. So what Tom Gillespie said is coming exactly true. This plan, and again, maybe there's other ones similar, will address Medicaid reform and help slow the growth of Medicaid in our state, which is absolutely necessary if we want to have extra money for roads, bridges, K-12, and higher ed. Finally, I would say this, the more we grow government health care, the worse our problems are going to get, because government health care underpays the medical professions for what their services are. Now, you had a section on waste, fraud, and abuse, right? And how to control that. More government micromanagers of the system, in my opinion, are not going to control that, because what we have, because of the expansion of government health care, we have an incentive for medical professionals to do additional charges on the private sector. In other words, if I have more and more patients coming in the door where I'm only getting reimbursed at 26%, in other words, I'm losing money on every deal and I'm making it up on volume, then as human nature, over here on the private sector side, I can actually make money on my services. Why wouldn't I incentivize as much additional diagnostic treatment and charges on the private side to make up for my losses on the government side? So we have a system that incentivizes medical professionals, and I'm not saying they're all doing this, to do excessive charges on the private side, to therefore make up the money that they're losing on the government side.
Representative Gruenhagen, I appreciate that, and I think that the committee does agree with you that to bend the cost curve downwards, particularly in all areas of the market, but certainly the public plans as well, is an important goal of ours. But in terms of the specific family medical accounts, could you perhaps provide the committee with maybe 3 or 4 bullet points as to what you see the family medical account actually doing and why it would work to specifically reduce the growth of the medical assistance portion of the Minnesota budget for healthcare?
Okay, thank you, Mr. Chair. Well, I think the presentation covered a lot of that, but it addresses administrative costs. You also have an incentive for Medicaid patients now to choose more wisely their health care, because similar to an HSA, even though this isn't exactly one, they can actually they're spending money that they could save for themselves down the road. And human nature being what it is, when you can save money for yourself by choosing more wisely the services you have, it creates a natural incentive to do so. So what you cannot mandate through laws, regulations, and more insurance and government bureaucrats, you can, by understanding human nature's general desire to get the most bang for the buck. And that's what this begins to do with the Medicaid population. Not the disabled or our nursing home, but the able-bodied people. So I believe that's one of the keys. The second key that was talked about was the administrative cost savings, Connecticut experience. And also, I think another great benefit of this is freedom of access to providers. As the presentation showed, the number of providers willing to accept Medicaid rose by over 20-some% in the state where this was initiated. We know that Medicaid acceptance by providers nationally and even in the state is declining, again, because of the low reimbursement rate. So those are just, some initial comments I would make as far as the benefit of this program. I think it takes us in the direction of reform, cost control, and empowering the patient to shop the market. And again, if we do not reform Medicaid, I agree with Tom Gillespie's conclusions, and you can review those for yourself. Finally, I would just say this. When I was just to the doctor recently for a little infection that I picked up from bumping my knee. Anyway, when I went into the doctor's office, there was a nurse with me, and I started looking around the office behind the examination table under the desk, and she said, well, what are you looking for? I said, I'm looking for that invisible government bureaucrat, an insurance bureaucrat that's in this room that's going to tell us what kind of care, if I get care, and when I get care. And, and that's where we're at, ladies and gentlemen. She just laughed, and she said, you know what? I fight with the insurance and the government people every day to get the care for people that they need. Think of the amount of wasted time that is being spent by the medical professionals trying to get the care they believe the person actually needs, and the person on the other end of the line is not a medical professional 90% of the time, and all they're trying to do is control cost, not get the person the care that they need. We've got to reform this if we want to keep the type of access and excellent care that Minnesota has experienced. If you'd like me on the committee to liven things up in the future, just let me know. Okay.
Thank you, Representative Gruenhagen and Dr. Geist. It appears that the FMA is something that would provide the opportunity for the participant to have skin in the game, enhance their motivation to be as wise a consumer as possible, provide broadened access. A fixed amount of dollars on the state part would be able to be calculated, whether it's a pilot program or broad-based, and then it would also have an impact on the dignity in the sense of the participants, that they would be engaging the healthcare system like people in the private or employer sector. So thank you very much for presenting. And any other questions from the committee? Thank you very much. Moving on to closing up the meeting, we have another meeting next Thursdays, September 14th, and that'll be at 1 o'clock. The agenda has been put together. Has that been sent out? We'll get it out soon. Are there any topics that committee members would like to put forward that they'd like to see specifically on the agendas over the next 2 months? Thank you, Senator Pratt.
Thank you, Mr. Chair. You know, we had a little bit of discussion around the fraud and abuse, and it's easy to, we've been hearing about fraud and abuse in the system for years without any specifics, right? It becomes this big nebulous, but to see that it's accounting for 30% of the cost of health care seems to me to be, I don't know if it's low-hanging fruit, but certainly something that we should be looking at and understanding better. And so if we could get some more specific information around where fraud and abuse in the system lies, and maybe help inform us as legislators how we might be able to, where it might be appropriate to attack it and where we should be relying on the professional standards and oversight to take a look at that.
Thank you, Senator Pratt. Senator Wickland.
Yeah, within that, I guess I would be interested if we are going to discuss the reduction of administrative complexity. That was a large segment of the 30%. Excessive administrative complexity was, I think, over 20% of that, 30%. So.
Thank you, Senator Wickland. Senator Klein.
Mr. Chair, so in terms of actionable things we could take forward, I was thinking a lot about what Senator Wickland had referenced earlier in terms of, do we have a function within our state government to do some comparative effectiveness data gathering and make some decisions about, this new medication is not more valuable than this old medication, which is cheaper. This surgical procedure is unnecessary and we don't want to reimburse it. And I think, we do have great clinical resources within Minnesota with the Mayo Clinic and other clinician leaders. And I wonder if we could look at legislation this coming session to establish public-private partnerships to do some in-state comparative effectiveness data analysis.
Thank you, Senator Klein. Any other comments? Okay, seeing none, we will reconvene on September 14th at 1 p.m. The meeting is adjourned.